Hey guys, so today I'm going to be talking to you about laryngeal spasm. So I'm going to go over two nerves. So the first nerve that I'm going to be going over is the superior laryngeal nerve. So if you look at the picture at the top, the superior laryngeal nerve is this nerve over here. And it actually has two branches. So it has the internal branch and then it has the external branch. So the internal branch of the superior laryngeal nerve, this one's going to be in charge of sensory innervation above the vocal cords. And then the external branch of the superior laryngeal nerve, so this one's going to be in charge of motor innervation to the cricothyroid muscle, so this muscle over here. The second nerve that we're going to talk about is the recurrent laryngeal nerve. So the recurrent laryngeal nerve is, if you look at the picture, the one at the bottom over here. And the recurrent laryngeal nerve is going to be in charge of sensory below the vocal cords and motor innervation to all of the intrinsic laryngeal muscles except the cricothyroid muscle. So important, recurrent, it's going to be sensory below the vocal cords, and then it's going to be motor innervation to all of the muscles except the cricothyroid muscle. So the cricothyroid, just remember, it's going to be the superior laryngeal nerve and it's going to be the external branch. And then for the superior laryngeal nerve, it's going to be, for sensory, it's going to be the internal branch. And it's going to be sensory above the vocal cords. Another important thing is to remember is for superior and recurrent laryngeal nerve, both of these are branches of the vagus nerve, so cranial nerve 10. And for the recurrent laryngeal nerve, so there's a right and the left. So the right one, just remember that that one's going to hook underneath the right subclavian artery. And then for the left one, just remember that that one's going to hook underneath the aortic arch. And here's another picture. Sometimes it helps to look at different views. Okay, and another important thing to keep in mind is that laryngeal spasm is a physiologic response. It's not a pathologic response. So it's just a reflex that our body does in order to try to protect us. And what can cause or trigger this reflex? So it's whenever substances come into contact with the vocal cords. So whenever this happens, such as, for example, saliva, the superior and the recurrent laryngeal nerve are going to mediate the reflex closure of the vocal cords. So you have saliva sitting there, it comes into contact with your vocal cords, and these two nerves are going to close that vocal cords in order to try to prevent it from entering the trachea. And the highest incidence of this happening is during induction and during emergence. And when we're talking about stages of general anesthesia, so the highest incidence of laryngeal spasm is going to be during stage 2, the excitement phase. That's why we want to try to get them through stage 2 as fast as possible and going into stage 3 where we want them, in order to try to prevent laryngeal spasm from happening. Okay, so like I mentioned, highest risk would be during induction and emergence. So who's at highest risk during induction? So it's going to be poorly controlled GERD. It's going to be long-standing diabetics. It's going to be gastroparesis, and whenever aspiration occurs. So all of these have an increased risk of a substance going in contact with your vocal cord, so there's going to be an increased risk for laryngeal spasm during induction. And for emergence, another high risk. So just remember, whenever our patients are under anesthesia, they don't have that ability to swallow the saliva. So that's why it's always important whenever you extubate or whenever you remove the LMA, the most important thing that you need to do is suction, because they're going to have that saliva just sitting there. So as soon as you deflate the cuff, they're going to be at an increased risk of laryngeal spasm. Okay, so here's Michael Scott, and his patient's having laryngeal spasm, and he's wondering what is he going to do next. So the first thing to do is, remember, for laryngeal spasm, your patient's going to be desatting. So first thing to do is 100% FiO2 at 10 to 15 liters per minute. Second thing you're going to do is you're going to give your patient continuous positive pressure ventilation. You're going to set the APL valve to 70. Just remember that you want to give sustained positive pressure for at least 20 to 30 seconds, and you might even need a second person to help you do mask ventilation if it's necessary. And if that doesn't work, then the third thing that you would do is Larson's point. So Larson's point is a known trigger point that often helps break laryngeal spasm. This is between the mastoid process and the mandible, and you're gonna apply firm inward and upward pressure. And hopefully this should break the laryngeal spasm within 20 to 30 seconds. But if that doesn't work, then the last thing that you do is that you're gonna give succinylcholine, 20 milligrams IV or 50 milligrams IM, in order to paralyze the vocal cords and stop the laryngeal spasm. Just keep in mind whenever you give succinylcholine, there's a high risk of recrudescence happening again. So high risk of laryngeal spasm reoccurring again. All right, thank you.